Trams, and today we have invited Matt Ignacio to speak on client, family, and community education. This training series is brought to you by the National American Indian and Alaska Native Education Technology Transfer Center. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designated to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence in treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Please check out our other upcoming webinars in this series, as well as our American Indian and Alaska Native Behavioral Health series, which takes place on the first Wednesday of each month. We always welcome suggestions of topics or speakers, so feel free to make suggestions either in the Q&A pod or by contacting me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and CEHs are available on request for a $15 fee. A request form is available for download in the Files pod in the webinar screen, and we will also be sending this form out in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GPRA evaluation. GPRA stands for the Government Performance and Results Act, and SAMHSA, our funder, asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so if you have questions about the presentation or the Adobe Connect system, please use the Q&A pod by typing them in the field at the bottom. We will address questions at the end of the session today, but please feel free to submit your questions at any time throughout, and they will get addressed once we get toward the end of the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's webinar is presented by Matt Ignacio. You may find Matt familiar. He's been doing a few webinars for us this summer. Matt has been working for us at the National American Indian and Alaska Native ATTC for a couple of years now as a senior behavioral health consultant. He's helped us work on some new curriculum. And we also wanted to mention that he has previous experience working for NAPC, which is the National Native American AIDS Prevention Center, as a project manager where he oversaw federally funded training, education, and capacity building assistance programs. So there he was a national trainer working with tribal communities, tribal health departments, state health departments, and federally qualified health centers and community-based organizations. So this really sets him up well for today's topic. So I'm going to bring up his slides a moment, and we'll pass things over.
Great, thank you. Good morning. Again, my name is Matt Ignacio, and I'm a member of the Tohono Nation, which is a tribal nation located in southern Arizona. So good greetings to all of you. I hope you all are having a great day. And thank you for taking time out of your busy schedule to talk about HIV. It's a really important issue in Indian country, and we can all play a role in helping to reduce incidence of HIV and help prevent the spread of HIV and help promote the care and wellness of those impacted by HIV, so as well as STIs and other related health disparities. This is a pretty solid presentation, so please feel free to type in any questions you have as I'm going along in the Q&A box. Any questions you type in there, I will see, and I will certainly answer them probably closer towards the end of this presentation, because I want to get through the material. But as questions come up, please feel free to type them in, and there will be an opportunity, again, like I said, for Q&A at the end. So there's some basic goals and objectives this morning, really. For those of you on the West Coast, I'm calling in from Seattle, so I say morning, but it might be afternoon wherever you are. And that's really to explain the basics of HIV prevention, as well as STIs, which stands for sexually transmitted infections. We really want to explain core components of prevention, as well as factors impacting risk. And then we'll close out with some strategies to help substance use providers, really all providers, in the effort to prevent HIV, STIs, and viral hepatitis. Also, if this is too quiet or if there's issues with the level of voice, please let me know in the Q&A box, and I'll be happy to adjust that as we move forward. Okay, so it should also be known that there are some core competencies with this training that go along with this training. Competency 106, really understanding and describing health and behavior problems. And Competency 105, describe principles and philosophies of prevention, which we will discuss today. All right, so let's jump in with HIV/AIDS. So the number of people living with HIV infection in the U.S. is higher than it has ever been before. So for those of you that, or many of us, I think,
You might have lost your audio, Matt. You may have to reconnect your microphone, or yeah, it looks like you're not just muted, but it looks like it might have disconnected. So Matt, you just might need to go through the steps again, up to the little microphone icon, and then click on Connect My Audio, and then choose using my computer's microphone and speakers.
it seems to be connected already.
Oh, there you are. Yep, you were back. Thank you.
Was something happened? Because it did drop.
Yeah, I'm not sure what might have happened.
We'll talk about it.
Okay.
We'll talk about it later.
Thank you.
I'm sorry. Sorry, folks. I don't know if that was mine, but whatever. We're moving forward. HIV statistics. So it should also be known that there are consistent increases in HIV rates, maybe due to a higher proportion of people living with HIV knowing their status, surviving longer with antiretroviral treatment, and being infected with HIV than the number of people who die each year with HIV/AIDS. So the point of this is that there are a lot of people living with HIV. A significant portion of those folks do not know their status, and therein lays a challenge. By region, this is based off of 2013, you can see visually which regions are most impacted by HIV. With the South taking up more than half of the pie with the number of cases. And then it looks like about, equal distribution for the other three regions, the West, the Midwest, and the Northeast. These are some other, these are risk categories with who are actually infected with HIV. And we can see that white MSM, men who have sex with men, is pretty high, as well as black men who have sex with men, and then on down the list. Now, you might be asking yourself, just based on the slide, if you didn't know what it was saying, well, I see race and ethnicity, but I don't see American Indian, Alaska Native represented on this list. And we'll talk about that. It's a larger systemic issue. But this is how the CDC puts out the information. So to me, it's a little incomplete. You might be feeling the same way, and we'll talk about that. So, how do folks become infected? Well, most commonly, it involves sex without a condom. So, unprotected vaginal sex, unprotected anal sex. The other most common route folks become infected with HIV is sharing syringes that were previously used by another injector. So, the blood-to-blood transmission. What we do and what we can say, what we can be somewhat proud of, or at least feel that we've accomplished in some areas with regard to this epidemic, is that we've almost eliminated HIV transmission in the United States through occupational exposure. So if you're getting picked up by an emergency room and folks are, you're unconscious and folks are ripping off your clothes and you have a syringe in your pocket and the medical team doesn't know that and they get accidentally pricked, or if a healthcare provider is, for whatever reason, emptying one sharps container into a larger sharps container and accidentally gets stuck. We have ways to address that post-exposure to help eliminate becoming HIV infected. So we've almost eliminated that route of transmission in the United States. Another way we've almost eliminated your risk of becoming HIV positive is through blood transfusions. Prior to, I can't even tell you the date, but the Red Cross systematically tests blood products for HIV as standard protocol. So we screen blood products that way. So if you go into a hospital and, heaven forbid, you have to have a blood transfusion, know that that blood product has been tested for HIV, and, we can say with certainty that your risk for becoming infected with HIV via that route is pretty small. And then another way we've been successful in eliminating risk for HIV is parent to child. So we can do prenatal HIV screening. We can know if the mother is HIV positive, and there are steps that can be taken before the baby's born, after the baby's born, to reduce their incidence of becoming HIV positive. So let's talk about once someone does become infected with HIV. There is a sequence of events. So when you've been exposed to HIV, what we might call that as acute infection. That's the viral transmission of HIV into your system. And you might experience flu-like symptoms as that's occurring. So sore throat, rashes, night sweats, fever, fatigue, thrush, which is a rash, on your tongue and inside your mouth. So I've been told by folks I've worked with that when they were, they didn't actually know they were HIV positive, but that they felt like they were hit across their body with a 2x4, and they were bedridden for 3 days. And once those few days passed, they actually were back on their feet. So to me, it's been described as something that's very serious, and that you probably would go see a provider for to get some help with. Beyond that, after that acute infection phase, which can last from days to weeks, there might be a period of asymptomatic infection, which can go anywhere from 2 to 12 years. Your body's producing HIV virus in your body, and simultaneously there's a depletion of your CD4 T cells, which help fight infection. If the individual who is infected continues on with no intervention, no treatment, no medical care whatsoever, eventually what's going to happen is there will be an AIDS diagnosis, meaning your CD4 counts, T cell population will be so low, be below 200, and the HIV will be replicated in your body to such large amounts that you then will be diagnosed with AIDS. And in my experience, because the medication and prevention and strategies to reduce HIV infection is pretty effective, I don't usually hear the word AIDS diagnosis anymore. That might have been the case early on in the epidemic. What is now commonly referred to as end-stage HIV, as opposed to AIDS diagnosis. And the reason why they changed the language just slightly a little bit is because it is manageable. HIV is no longer a death sentence if you have access to the care you need. People can live long, healthy, happy lives, if they get into care and remain in care. It's what otherwise can be referred to as a chronic manageable illness, much like diabetes. So I just want to point that out. As well as, opportunistic infections actually can happen anywhere on this sequence of events. That's actually how you can discover you have HIV. You might get pneumonia, or you might get, trying to think of the other, there's a list of opportunist infections. Once you get diagnosed with an opportunist infection at any of these phases, chances are you are in some kind of care and that you will actually be linked to services to help get that treatment going, because doctors want, we want you to live, we want you to survive. Okay. Next slide. This is looking at the treatment cascade, and many of you may have already seen this. And what I want to point out on this slide is that everybody look at the first bar on the bar graph. Those are the folks that are estimated to be infected with HIV in this country. So 1.1 million people are living with the virus, going on about their lives, doing what they do. As we move along the treatment cascade, you'll notice that the number decreases by, okay, so we know the number of people, or we can have a pretty solid estimate of those who are infected. The next bar over is like those who actually know that they have the virus. So we're looking at 874,000. Even smaller are those that are actually linked into some kind of HIV care at 655,000. Even less are those individuals who actually stay in care. Even smaller are those who actually may be in care but are in need of some kind of antiretroviral therapy. On and on until we actually get to the smallest bar, 209,000 folks, who actually are in care, remained in care, and are who are adherent to their treatments and actually have undetectable HIV virus in their blood. That is the gold standard. We want all 1.1 million people to get to the adherent undetectable column. As you can see, there's a lot of work to do. Now, I ask you to think about your own communities. If you know of folks, or if you can just imagine folks in your community who might be living with the virus, who don't know their status, what are the chances are? The chances are greater that they're actually going to possibly spread the virus without them knowing. That's how this virus spreads, right? In contrast, if you actually knew you were HIV positive and on medication and you were adherent and your viral loads were undetectable, as this treatment cascade shows, those 209,000 people are less likely to spread the virus to others because their viral load, the HIV virus in their body, is so low that it's less likely they can transmit it. And, they're living long, healthy lives. So we want to get folks over to the right side of the graph. With regard to treatment as prevention, research has shown there are added values of antiretroviral therapy. That's the medication that effectively treats and prevents HIV. Reduce the viral load significantly, decreasing the likelihood of transmitting the virus. And a person not living with the virus can now take the HIV medication to protect themselves from infection. I mean, the medication is that great that if you are HIV negative and you are engaging in risky behaviors, you use condoms and take other prevention measures in addition, you can actually be prescribed HIV medication and take one pill a day, and it'll even reduce the chances of becoming infected even less. I mean, I think it's got upwards of a 99, 98. This is just off of memory. Don't quote me on this, but it's way up there in terms of effectiveness. And that is called PrEP, and we'll talk about that. All right, so I've mentioned it before. Let's talk a little bit more about linkages to care. To me, this is where, particularly in Indian country, if you're working in a small rural community, you might actually have opportunities for people to get tested, But think of those people in your community. Should their results come back positive and they are diagnosed HIV positive, where in the heck would you send them for good, high-quality care? Someone who specializes in HIV. Therein lays an issue common in Indian countries, is linkage to care. So, structured programs to move people, this is a definition, structured programs to move people from diagnosis into stable care. There's going to be some work working through barriers, fears, and misconceptions. There will be challenges with administrative barriers. And there are now issues around navigating environmental barriers. What about confidentiality? Will they see me going into that doctor's office and know why I'm there? These are all issues that are actually real. I mean, this is what prevents somebody from getting an HIV diagnosis and then not following up for a year or two, finally addressing the issue. Linkage to care also means evaluating available care options. Affordability, Ryan Care Act. If you get linked into care, actually, a really good case manager will be a partner and help navigate those systems. Linkage to care programs are not required for all people, but there should be a requirement for all programs. Okay, I'm going to switch gears and let's talk about sexually transmitted infections. So in general, there are three sort of families, if you will, of sexually transmitted infections: bacterial, parasitic, and viral. As you can see on the slide, bacterial, inclusive of gonorrhea, chlamydia, and syphilis. There are treatments that can actually cure those infections through antibiotics. Parasitic, such as pubic lice, crabs, and scabies, is also easily treatable and curable. Where we are working very hard to find cures is around, viral HPV, viral papillomavirus, human papillomavirus, HIV, which has really good effective treatments. The question is, do you have access to them? Herpes as well as hepatitis. Some can be treated, others, it's more of a managed chronic illness. All right, with regard to hepatitis C, newly infected are either asymptomatic or have mild clinical illness. Hepatitis C virus can be detected in blood within 1 to 3 weeks after exposure. The average time from exposure to antibodies to a hepatitis C seropositive diagnosis can be 8 to 9 weeks. Chronic hepatitis C infection develops in 70 to 85% of those who are infected. So what that means is there's actually a small amount of folks who will be exposed to hepatitis C and actually clear it on their own. Of those who can't clear it on their own, unfortunately, 60 to 70% of those folks will develop liver disease. Most infected persons remain unaware of their infection because they are not clinically ill. And I also want to mention, there are recommendations around who should be highly recommended to be tested for hepatitis C, and those are baby boomers and those who have histories of injecting drugs even one time. So if you fall into any of those two categories, or you have clients that fall into any of those two categories, we would strongly encourage them to be tested for hepatitis C. Oh, whoops. As you can see, these are the new hepatitis C regimens. Mainly what I'm showing you with this slide is that there are options out there. Some work better with some races and ethnicities. Some, have side effects. And I actually heard someone describe that the choices you make around hepatitis C treatment is about managing side effects. So what side effects you're willing to endure for a period of time to clear the virus from your body. And that's a conversation you have with your care provider or your client's care provider. Let's talk about hepatitis C and HIV co-infection. So routine testing for hepatitis C for any HIV positive person is critical. So if you know somebody who's HIV, if you have a client who's HIV positive, certainly we need to get them tested for hepatitis C, which is not always done. Early diagnosis, evaluation, and treatment of Hep C should be considered for HIV patients because hepatitis C certainly can create complications, right? And it can actually also create challenges with medications. So it's just good practice. I mean, let's just get in the habit, right? So if we have clients who are HIV positive who don't know their hepatitis C status, we can do a little better there. We can encourage them to get tested. So there are prevention opportunities in existing programs. So all programs, we can say that we know that clients in education need risk screening and counseling. There are hepatitis A vaccinations, hepatitis B vaccinations, and we know there are hepatitis C screenings, counseling, and referral services. We just need to get tapped into it if we're not familiar with it. And I even want to go so far to say, and I'm pretty sure this is a true statement, again, don't quote me on this, that all states, or if not all, most states, there is a viral hepatitis coordinator for each state, and that's somebody that you could look up, find out who that person is and get more questions answered if you need. All right, prevention. Let's all talk about prevention. There are levels of interventions with regard to prevention. Interventions refer to the mechanism and strategies used to operationalize a level of prevention. So what would you do to promote the idea of using condoms? Something that we talk about, I think in the very beginning of HIV, in the early 80s, prevention measure, maybe the mid 80s, a prevention measure might actually, has been, and consistently has been, to use condoms correctly and every time someone engages in intercourse. That is, we think of Indian country with regard to condom prevention messaging. I can remember a time when I first started working in HIV when condoms, we'd go to native wellness conferences, and we'd set up a table. We'd have our, I worked at the National Native American AIDS Prevention Center. We'd have our table, our little booth in the exhibit hall with our Pendleton blanket out on display and our brochures and our booklets, and we'd have baskets with condoms in it and, a big banner that says National Native American AIDS Prevention Center. And this is like the late 90s, early 2000s. And I can remember other Native people, people, who you've been to a conference, you walk from booth to booth, one right after the other, down the row, right? Well, folks would actually, as soon as they would see our booth, walk all around the front of our booth to go to the next one and then continue on down the line. Strategically avoiding our messaging and the condoms, and the condoms would be a controversy. So the question is, what would you do to promote the idea of using condoms? And I know that's not always easy, depending on where you are, but that's the question. And that's an intervention, right? So interventions are the opportunity to directly connect with individuals, communities, or systems that are creating or perpetrating risk in order to eliminate, reduce, or mediate risk. Interventions always try to change something. So think of my example at the exhibit hall at the conferences. We know that HIV, we knew it then and we know it now, that HIV is a serious issue in the Indian country. Our intervention was to make condoms accessible and available to not just certain segments of a tribal community, but everybody. And unfortunately, that didn't always go well. People didn't like the idea. I can say now, though, that this day and age, there are condoms at powwows now that, the MCs at powwows will announce that there are condoms available. Please visit this booth. Conferences, native and non-native, certainly embrace the idea of distributing condoms. Tribal health centers certainly can make condoms available in their facilities. So I like the fact that we've moved in that direction. Okay, so what is most effective in structural level interventions, community level interventions, group level interventions, and individual level interventions? As you can see, it can involve policies and systems. It can involve community level norms, such as making condoms available at powwows. It can involve individual behaviors through group settings. So conducting a condom demonstration group for teens so they know how to actually use them. And as well as individual behaviors. So it's one thing to actually know how to use condoms or what they're for, but then it's another thing, it's another step to actually provide somebody with knowledge and skills to then be able to negotiate condom use in the heat of the moment. So which one do you choose in thinking of your own community? Well, let's think about your own community and risk populations. What is appropriate for them and what is appropriate for the issues that you all are facing? Look to the science. What has been effective? What has worked in the past? What is affordable? Not all health centers can afford condoms. They can be, there can be a price tag associated with that. And certainly doing a cost-benefit analysis can help determine what might be best. So we should also note that one does not necessarily lead to the other. What I mean by that is, just because there has been exposure, so there can be high-risk incident exposure, but that doesn't mean someone will become HIV positive. There can be exposure and transmission. Again, there are steps that can be taken to prevent the transmission of HIV. When someone has the virus, there are steps that can be taken to keep that person well and keep them to be able to live long and healthy, happy lives. And there are steps that we can take when someone is infected to help curb the spread of HIV. So there are many levels of ways we can all intervene. All right, I want to steer focus now on looking at substance use treatment providers and how substance use treatment providers can play a role in helping to prevent HIV, hepatitis C, and sexually transmitted infections. All right, so why us? I mean, substance use providers have a long laundry list of things to do, and probably large caseloads, probably, challenges with funding, and probably may not feel so comfortable or readily confident to talk about HIV. But there's a reason why substance use providers are one of the most ideal candidates to help prevent the spread. So, substance use providers, have experience with behavior change and what that means. They understand behavior change. You will all know the stages of change. You all have a sense of what motivational interviewing is. You all know how to help set realistic goals with your clients and adapt them as you move forward. You all know how to create an warm, inviting atmosphere where you are not judging your clients, but you're there to help them. So the environment is right. Substance use providers certainly have experience engaging with high-risk clients daily, the folks probably most at risk for acquiring HIV. We didn't mention earlier on the other slide around risk factors for HIV, but it should be noted that if you're actively using drugs and alcohol, your risk just went up for acquiring HIV. Why? Because we don't always have, we might make different decisions when we're under the influence. And you all know that. Substance use providers certainly can instill a sense of accomplishment among their clients, foster self-improvement, and just have an inherent value of health seeking. We recognize when people are doing that and we support that in our work. And certainly substance use providers reduce the number of injection drug use occurrences and HIV risk behaviors under the influence. So if you're a substance use provider, you know that injection drug use is a risk. And if your client is actively injecting, you can strategize with your client to find ways to use sterile syringes each and every time they inject, or you can work with them to wash their syringes with bleach. There are ways we can intervene all along in this process, regardless of the client and their presenting problems. So, people living with HIV require HIV treatment and disease monitoring. Certainly, they may be hesitant to access medical care systems, particularly Native clients. There certainly is they may require constant medical monitoring. And then clients may not have insurance or know how to access care. Well, service providers certainly can help be the bridge. And we need the help, right? Prevention as a core function. Prevention seeks to interrupt the spread and perseverance of a condition. Substance use and certainly sexually transmitted infections, HIV, can all be prevented. So prevention is a core function of public health and behavioral health practitioners. All right, so let's talk about the who, how, where, why, when, and what. So given current prevention foci, we have two. We're focusing on biomedical, which is your HIV pills, medication, either if you're HIV negative or positive. It can be the use of condoms. It can be following up with care with your regular visits. It can be even, if you're HIV negative, getting regularly tested either annually or every 6 months, depending on your risk behaviors. Those are all biomedical interventions. In addition to, another foci is looking at behavioral prevention. So, talking about somebody's risk, asking questions about, do you know how one becomes HIV positive? Do you feel comfortable discussing condom use with your partners? Do you know how to bleach your syringes after you inject? And teaching somebody the skills around that. Those are behavioral. Behavioral interventions involves examining the individual and community psychosocial components of behavior and implementing strategies to alter them. So again, teaching somebody how to wash their syringe with bleach is a behavioral intervention. And that can be delivered through individual one-on-one skills building interventions. That can be delivered through group level. So if you have a group of folks who are injectors, you can hold monthly classes on how folks can protect themselves, health education classes, how they can protect themselves and enhance their wellness. Or you can have a community behavioral intervention where you work with law enforcement, you work with tribal police, you work with emergency room staff, and you inform them of the services that you can offer, and you can get referrals that way. Looking at biomedical involves the use of medical science to intervene in the biological and pathological operations of the virus or bacteria. So, treatment. If you have pubic lice, you go into a doctor, you get checked out, they prescribe you shampoo or a cream, boom, you're good. You're HIV negative, you put yourself at risk, you still continue to use condoms accurately and every time, you might be prescribed and be an eligible candidate for PrEP, which is pre-exposure prophylaxis, which is HIV medication. You can take that daily and prevent you becoming infected with HIV. You know that if you are working in a healthcare facility and you get accidentally pricked with a contaminant or a syringe and you don't know whose syringe that is, or you're immediately worried that you might be exposed to HIV, you can get on PEP, post-exposure prophylaxis, which is a 30-day regimen to help greatly reduce the chances of you becoming HIV positive. Certainly microbicides and gels is also another area of HIV research right now. creams, foams that can be used to help prevent the spread of HIV inserted either vaginally or anally. And circumcision is another biomedical intervention. So there's a menu of biomedical interventions. Again, the question is, when I say you, I mean either you or your clients. Does somebody have access to these interventions? That's the golden question. And it's going to vary depending on where you live. So ideally, in a perfect world, right, we'd like to see a combination of both biomedical and behavioral interventions. There is certainly expedited partner therapy. We can get folks tested, we can get folks on PrEP, we can certainly talk about medication adherence. Those are all sort of listed as combinations of both. All right, so let's look at biomedical factors that affect transmission. So if one has a viral load that is super high, that increases the risk of them transmitting the virus. If somebody has a super high viral load and is under no treatment, again, that's going to increase their risk for transmitting the virus. If you are HIV negative and you have a sexually transmitted infection, such as syphilis, you are then more likely to become infected with HIV. Why? Because your immune system is already compromised, and the theory is that within a compromised immune system, it makes it 3 to 5 times more likely that you will become HIV infected. So if your clients currently have an STD, or a sexually transmitted infection, we want to get them treated for that. We don't want to let that, we don't want to ignore that. And there are some social and behavioral risk factors. Those certainly indirect aspects that can contribute to risk. Certainly are the people that we are engaged sexually with, our social networks, and our substance use certainly can all put us at risk. There are community risk factors, such as poverty. I mean, come on. If you're living in a community where the poverty rate is really high, and folks are just trying to survive, just trying to eat and trying to maintain the basic necessities of life, their concern for HIV is going to be a little further down the list. So that can place folks at risk. Certainly along with that is homelessness and access to prevention and treatment resources. We have all these wonderful interventions, but if you live 200 miles away from the closest health department, we've got some challenges, right? And that's something that's going to need to be addressed head on, one way or another. And certainly the family plays a role in all this. As a primary vehicle for socialization, families certainly can create social support networks, foster access to health care, model positive communication behaviors, and provide opportunities for dialogue. In the long run, family roles certainly value open communication about personal issues, value norms around diversity, normalize sexual behaviors and be sex positive, and combat gender norms. Now, I don't know about you, but in my own life, and it wasn't necessarily my hang-up. Oh, no. Yeah, it was my hang-up. It wasn't my family's hang-up about discussing sex. It was my own discomfort talking about sex. So family can be a great support, but it's going to, it takes time to work up to a level of comfort where we can achieve where families can be a primary support system. And I've said this example in the past, and I'll quickly say it again. There was a client who was living in a rural part of the country that I was working with, and she, would miss her appointments, and she was native mom. I'd never met her family. Living in a rural part, she'd be hit or miss with her appointments. She wouldn't, necessarily fall through. Her adherence to medication, to her HIV meds was, not the greatest. And then all of a sudden, over time, what quickly happened, but what seemed to be sustained, was this night and day change. Suddenly now, she was adhering to her medication, and she was coming to her appointments, and it was time to do a home visit, and I went over there, and I wanted to, ask her about, like, why all of a sudden is she now, being a rock star. And essentially what it came down to were the kids were there at the house, and the kids had put up a calendar on the wall in the family room and would, race to be the one to mark off the day that their mom took medications, so that it became this like kind of activity for everybody to be sure that if mom took her meds, they got to mark the day off with an X on the calendar. Pretty ingenious, right? Not only that, the support she got around transportation to get to her appointments became a priority within the family unit. I cite that example just to point out that family can be really, really instrumental in our health and wellness, regardless of what we're going through, right? And furthermore, family doesn't always necessarily mean blood relationships, particularly in communities. Family could be your in-laws, your distant cousins, clan members, your neighbors, what have you. But I just point that out because it can be, and we should not minimize the role family can help and can play in maintaining all of our health and wellness. Furthermore, community certainly has a role and a responsibility to establish resources and access to HIV and substance use, as well as hepatitis C. Create policies that emphasize health and wellness and not create barriers, right? Communities have opportunities to shape norms around sex, drug use, risk reduction, reducing drug-related harm, and gender equality, as well as sexual orientation equality. Certainly, communities can encourage sexual and substance use education in schools, and communities can also help to create policies around syringe exchange programs, as a way to reduce HIV where they live. Systems. Think of systems like the federal systems or your state or your tribal healthcare systems. They all play a role as well. Systems are the mechanisms through which formal services are delivered. Certainly, there needs to be a level of what the community needs are. I can say not all systems understand those needs. Systems certainly align services to community needs and community culture. That's may or may not be true. Systems can work to alter potentially harmful community norms, yes. They can also ensure access to services. They can try. They can help with that. Systems can also design and provide services through a health equity lens. We work towards that. And as well as provide a list of preventative services and work to modify systems to accept a variety of health insurance. So, this is often where I seem to find myself with regard to advocacy, because not all this happens, and maybe it happens for some communities and not others, and we need more work. And it's just important to put this out there, because when we're preventing any health issue in our community, these are the different levels that we all work on. Some of us are more equipped to work on the front line and, keep their finger on the pulse of current trends. Other folks feel more comfortable working more on policy level or on the community organizing level. I mean, it's all about finding where your skill set is. And each person has a skill set, and it's all valued, and we need everybody's. Now think of community viral load. This is a newer term, and what it actually refers to is looking at the community as if it were an individual person. So think of your community as an individual entity. Just like a person, it too has a viral load. And a community can have the same, so it can have a viral load. So let's, I don't want to, I was going to have an example, but I'm backing out on that one. What is your community's HIV viral load? And what can be done to lower your community's HIV overall viral load? Can we look at maybe some prevention strategies? Can we maybe incorporate some treatment strategies? And this data actually is calculated and collected through the CDC. So this is not, I'm not just bringing this up to talk about it, it actually is a real thing. All right, getting back to what we do as substance use providers with regard to hepatitis C, HIV, and sexually transmitted infections. Certainly from a clinical individual perspective, we can include indicators for HIV, STIs, and HIV risk in all of our assessments. One quick question you could ask is, have you had an HIV test in the last 12 months? Boom, easy done. Person says no, you know what steps to take next. If they say yes, boom, you can follow up with them in a year's time. And also actually ask if they know what the actual status is. We can include actionable items. So in treatment plans, we can say, this person is HIV negative, was tested 3 months ago, is interested in getting tested again, referred to HIV testing site, will follow up in 3 months. These are all actionable items that are realistic and doable. We, when appropriate, can include families and partners in counseling sessions. And we can also examine environmental and social factors, not just with drug use, but with sexual health risk. We can also, we can do screenings, we can provide referrals. It might take some training, but discussing medication adherence with regard to HIV, I mean, if you are HIV positive and you're on the latest medication or one of the latest medications that's 1 pill a day, the adherence to that is pretty high. Like you can't miss too many doses before your body or the virus develops, can develop resistance to that particular drug, that medication. So it's critical that folks who are HIV positive and on treatment stay on their treatment and adhere to their treatment very closely, because once they stop taking the meds, that's when the virus will produce a resistance to that medication. And then when they get back on medication, that medication may no longer work, and then they may need to be prescribed something different and a little bit more intense. I can tell you that I have known people who have ran the gamut and ran the course and have gone through all the medications and now don't have any options because they weren't able to adhere. So I think that's an area worth pursuing further. Maybe that's a 2.0. How do we motivate? How do we encourage? How do we support folks to stay on the medication that they need to? And this isn't just HIV. We could actually take hints. I know diabetes has those trainings in place and has curriculum already set. Maybe it's a matter of us talking across disciplines, talking across hallways, talking to our neighbors down the hall, and asking what's worked for them. And certainly providing basic HIV education and sexually transmitted education to your colleagues. And it's okay if you don't know the answers, but just creating an opportunity to, do you have any questions? What questions can I answer for you today? Leaves the door open, and maybe not today, maybe not next week, maybe not next month, but if you're consistent in keeping that door open, folks will come. They'll eventually come and ask questions. Substance use providers can also look at environmental factors, right? So creating an environment where it's okay to discuss sexual behaviors. Serve as a conduit for information, certainly between individuals and families. Making condoms available. Again, not always easy, but possible. And programming that makes syringes more accessible for high-risk users. And with regard to social and community factors, certainly we can help to create programs that combat community norms that are negatively impacting. So things like thinking around folks who inject drugs. So banishing them from the community, or creating services that do not affirm their identity, but basically vilify or demonize them for their drug use. That's not good, right? We can support programming that is age, gender, sexual orientation, and culturally appropriate. We can facilitate insurance enrollment as part of long-term recovery plans. certainly implement cultural practices wherever and whenever possible, engage families in longer-term treatment plans, and discuss peer norms and pressure and as a risk factor. Certainly looking at structural and system level issues, we certainly can we can do our jobs and deliver the required preventive services, implement widespread and mandatory screenings. So one clinic I worked with in helping get their HIV testing program up and running, they were able to change in their electronic chart system that it actually would prompt the medical assistant to ask, have you had an HIV test? When was the last test? Do you know your status? And if someone did know their status and they were recently tested, it would know in the system to automatically pop up a calendar year later to ask the same questions again. Those are structural, systematic ways we can address HIV. We can also train providers on cultural appropriateness, humility, and relevancy. We can engage in systematic quality improvements to ensure that programs are operating effectively. Support training and development for longer-term interventions, and certainly work towards equity in access and delivery. Often what I saw is that folks had really good intentions and providers had really good intentions and well-meanings, didn't necessarily have the skill set around HIV, sexually transmitted infections, but wanted to help. In combination with their agency, didn't have any money for training. So you might be wanting to do something, but don't know where to turn, and your organization isn't willing to fund a training, just send you off to a training. You know, organizations such as this very one we're working with today, the Native American Alaska Native Addiction Technology Transfer Center, is a start. Let's hit them up and ask them, do you know of any training opportunities that are regional, that are local, that can maybe even come to us directly at no cost? They exist. They're out there. Just a matter of connecting, getting connected. And certainly you can reach out to me. My email will be provided on the last slide, which we're getting close to. And also providers certainly, quickly talking about the Affordable Care Act. Preventive services certainly are now mandatory and covered by all insurance programs. So these are the list that the ACA covers. Alcohol misuse screening and counseling, depression screening for adults, HIV screening, immunization vaccines, inclusive of hepatitis A and B, as well as HPV, sexually transmitted infection prevention counseling, and tobacco use screening and cessation interventions. So let's talk about integration. So let's put it all together. Let's be solution-focused, folks. Prevention services, when working with active drug users, certainly does require a positive service delivery model. What do I mean by positive service delivery model? Well, it's something you individually do every day and may just not know it. We all work from a strengths-based approach, right? We are collaborative with clients. We write down strengths as a way to empower them. This is something that I'll do. So the fact that folks come in for the appointment, boom, that's a strength. The fact that folks are willing to talk about uncomfortable topics such as their sexual risk behaviors, that's a strength. We can write that down and hand them that list and say, openness to discussion. Comes to appointments on time. I mean, though it sounds like a report card, but what it actually does is just affirming someone in their process, helping them take control of their own health. When we work from a positive service delivery model, we certainly can convey authentic interest. So rather than just, how would you say, like, hi, how are you? Let me help you. Okay, bye. You know, as opposed to, how are you doing? How's your family doing? Have a seat. Can I get you a glass of water? Tell me what's going on. You know, it's two different ways of interacting with the folks we work with. Obviously, if we want to build trusting and respectful and authentic relationships, we're going to take the time to do small talk. And as substance use providers, you know, there's a unique role that we all play with regard to advocacy. That you guys hold the frontline perspective. You guys know the emerging trends in your community. You guys know what real time is going on. What are the real barriers for folks to getting in treatment? That is such critical knowledge and information that you all hold that needs to be shared, both downwards to clients and communities so they're aware, as well as upwards to policy and system and structural levels. Because that's the way change happens. So that 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 holding that knowledge is an honorable thing, and I encourage you to speak up and advocate when you can, because you hold a very specific perspective. Okay, great. I can now have a sip of my coffee. I'll take any questions or comments. Hopefully you found aspects of that or a aspect of that helpful. And so if you have any questions, please feel free to type them in the Q&A. Otherwise, I'm going to actually post my email address. Please feel free to reach out to me if you have further questions. If you're interested in training opportunities, it can connect you with some folks. Certainly reach out to Kate and the team at the ATTC. They are exceptionally knowledgeable and know of resources. And I certainly just know that I support the work you're doing, and I pray for your own wellness and balance and any of the hardships you're going through, because I know the work is tough. And so thank you for doing all the important work that you do.
Okay, anyone, feel free to enter any questions you might have for Matt right now in the Q&A box. I'll wait a few minutes and then sort of shift over and do our closing slides, but do feel free to ask Matt questions. I know he's very receptive and helpful and willing to entertain any questions you might have. Okay, I'll start to close up now then. So if you don't have any questions, I'm going to start to kind of let you know what's going to happen next. Within the next 24 hours, you'll be receiving an email from the National American Indian and Alaska Native ATTC, which will include a link to the recording of this webinar, a link to the survey, CEU request, handouts from the presentation. We really appreciate your participation in our survey. It shouldn't take more than 10 minutes to complete, and it lets SAMHSA know how many people attended our webinar, how satisfied you are with the webinar, and most importantly, ideas you might have for future webinars and how useful you really found this webinar today. Our upcoming webinars include an August 3rd technology-based clinical supervision by Jenny Gringer Richards. That's actually me. And then followed by group counseling with Matt Ignacio again. September 7th, environmental literacy for youth. And then treatment knowledge on September 21st by Bob Rory. I want to thank you again for taking time out of your day to be involved in this webinar. I want to thank Matt so much for helping us out with this. We really enjoyed having you here today. So everyone have a wonderful day. Stay healthy and enjoy the summer.